Our lecture today is deformities of the knee. One of the important deformities of the knee is knock knee or juno valgum. Causes of the juno valgum: A. Idiopathic, which is the commonest type, mainly bilateral, may consider normal in pediatric. B. Bone softening, like in rickets and rheumatoid arthritis. C. Bone injury, like epiphyseal damage and fracture lateral tibial condyle. D. Thin cartilage like osteoarthritis. E. Stretch ligament like Charcot and adducted hip. Now we come to the clinical feature of idiopathic. Usually appear at the age of 2 to 3 years and recover at age of 6. Severity determined by the distance between both medial malleolus, like this picture you see, like this. Treatment: child seen at interval of 3 months. If by age of 4, intermedular 10 or more, intermedular 10 cm or more, the surgery is indicated. So that this is very important point to concentrate. If by age of 4, intermedular distance 10 or more cm, the surgery is indicated. Surgery in form of stapling the epiphysis in immature skeleton or supracondylar osteotomy after the growth completed. So there's two things: below maturity and after maturity. Oh, okay, or before epiphyseal closure, we can perform what's called stapling, or after that we can perform supracondylar osteotomy. Now we come to the other deformity. What is the bow leg juno varum? Causes: first, also a idiopathic commonest type. B. Bone softening like ricket also. C. Bone injury like epiphyseal injury and fracture upper tibia. D. Thin cartilage like osteoarthritis. E. Blount syndrome due to avascular necrosis of the posterior medial part of proximal tibial epiphysis. So this is picture show to you what you mean by the knock knee or juno valgum, or with bow leg with a juno varum. Okay, concentrate on this picture to know in the future what you mean by these two diseases. Clinical feature: child brought of bow leg or into gait. Severity measured by bicondylar distance. If more than 8 cm, further investigation is needed. Treatment: the deformity usually recovers spontaneously. If it is severe one, it was treated surgically by either stapling or epiphysis or upper tibial osteotomy in adult. Meniscal tear: there are medial and lateral menisci in the knee. They are avascular, so tearing is difficult to heal. It is semilunar, contained body and anterior horn and posterior horn. So the cartilage is semilunar. It means that it contains body and anterior horn and posterior horn. Lateral one is more mobile than the medial, so the medial is more exposed to injury. Medial meniscal injury here. It is happen by force grinding between the femur and tibia. This can occur in weight is being taken, the knee is flexed, there is a twisting strain. The initial split may be in the anterior horn or posterior horn or both, which is bucket handle tear. This picture shows you what we mean by semilunar, medial meniscus and the lateral meniscus. Okay, and what we mean by a tear, which is anterior horn tear, posterior horn tear, or bucket handle tear. All these pictures show to you what has happened. Meniscal tear pattern. This is show all the meniscal tear, vertical, oblique, radial, horizontal, and complex. Symptom: original injury, pain on the inner side, locking, swelling of the knee joint, further incidence with little force, the knee periodically give trouble and locking. What does locking mean? Lock knee means full flexion with inability to stay last 10 to 15 degrees. This is important. I showed you in the clinical session what we mean by lock knee. The patient cannot extend the 10 to 15 degree, the last 10 to 15 degree. Sign. What we mean by the sign, most patients fit young, athletic. The joint locked, tenderness and fluid in joint. Once an attack has subsided, tenderness and pain is completely disappear. Test. McMurray test, greenting test, destruction test. All these tests we take it in the clinical session. X-ray. Plain X-ray is normal. Arthrogram is indicated. MRI. Differential diagnosis of locking, this is important. Loose body, recurrent dislocation of patella, fracture of tibial spine. Treatment: either conservative indicated in the following. The patient is seen after the original injury and the joint is not locked. Attacks are infrequent, not disabling, and patient is willing to abandon activity which provoke them. Manipulative. It is indicated if the knee locked, which done by rotation of the joint in various degree of flexion. Operative. It is indicated in the following. If the joint cannot be unlocked, first, if symptoms are recurrent, meniscectomy is done either closely by arthroscopy or open surgery. Bursa. Now we come to the bursa around the knee. Pre-patellar bursa, infrapatellar bursa, popliteal cyst, which is the Baker cyst. You see this? Pre-patellar bursa. You see that? All this very important to see. We have other popliteal aneurysm, semimembranous bursa, and meniscal cyst. Causes of loose bodies: injury like in traumatic injury and osteochondritis dissecans. Degenerative like in a breakdown of osteophyte in osteoarthritis and in Charcot disease. Inflammatory like leakage of fibrinous loose body in a chronic inflammatory condition. Synovial chondromatosis, which is cartilage metaplasia in an area of synovium. Recurrent dislocation of patella. There are four types of patellar dislocation. First, congenital, which is displaced lateral and nerve returned to its correct position. Habitual, in which patella dislocate with even flexion of the knee. Third, traumatic. For recurrent dislocation of patella. Causal factor laxly common in cause of generalized hypermobility of knee, weak muscle, weakness of the muscle after traumatic dislocation of patella, especially vastus medialis, anatomical abnormalities, poorly developed arch or poorly developed arch on lateral femur condyle if patella too small or had. Pathology. The capsule on the medial side of the patella torn and if failed to reunite properly, lateral laxity will happen. Repeated dislocation will damage the surface of patella and femoral condyle. Degenerative changes follow which result in flattening of the condyle, so facilitating further dislocation. Symptom and sign. Sudden attack occur without injury and the patient may be thrown to the ground. The condition may be bilateral, usually a female. Apprehension test is positive, which is pathognomonic test. If the friction test positive, condemnation will be happen. Treatment. The main treatment is operative by repair of the medial tone, so the only effective treatment is operative. Realignment, it is usually combined by reconstructive surgery. There are two types of realignment, either Gold's weight or Hauser operation. Patelloctomy, it is usually indicated when there is chondromalacia patella or advanced patellofemoral osteoarthritis. Chondromalacia patella causes. The arterial cartilage of patella may be damaged by single injury, friction against ridge on medial femoral condyle, recurrent dislocation of patella, faulty path of patella during flexion and extension. You see this picture of patella dislocation, and you see this the chondromalacia patella with it. Causes of faulty path of patella. Disorder above knee like adduction deformity of the hip, medial displacement or fracture femoral shaft. Disorder at the knee like valgus deformity and high patella. Disorder below the knee like abnormal tibial rotation and foot deformities. Clinical feature. Gear young adult, trauma, diffuse pain in front of knee, diffuse pain in front of knee, occasional swelling, Q angle increase, friction test positive. Plain X-ray by skyline view is indicated. Treatment. Analgesia and avoid angio activity. Physiotherapy may help the patient. If symptom prolong, operation is indicated by realignment operation by either Gottwith or Hauser. Operation. Osteochondritis dissecans. It is mostly due to trauma. It is either osteochondral or subchondral. Commonly on the lateral part of the medial femoral condyle, it may be detached and become loose body. Young patient affected with pain and swelling of knee joint. Wilson sign consider a diagnostic test. Flexion of knee joint 90 degree and medial rotation of the knee lead to pain at the joint and relief by lateral rotation. Treatment: detached piece should be removed and cleaning with draining the crater. This shows you that the lesion in the lateral part of the medial femoral condyle, and it is either attached, remain attached or detached. If it is detached, so you have to remove that because it be a loose body, and we can drill the area. Or if it is still attached, so we can fix that by something later on. Osteoarthritis. It is a degenerative disorder of the medial aspect of the knee joint due to repeated trauma, dislocation, osteochondritis, and rheumatoid arthritis. Valves of the knee with pain and slight swelling of the knee, associated tenderness of the medial aspect of the knee joint. X-ray, the cardinal radiological sign are decreased joint space on the medial aspect of the knee joint, mainly this. Maybe if it happened in the lateral side, decrease the joint space in the lateral side. Osteophyte formation, subchondral sclerosis, and subchondral cyst. Treatment: either conservative, short-wave therapy, non-steroid or anti-inflammatory drugs, sticks. Night pain with medication indicate of total knee replacement. Night pain with medication. You give the patient medication, still the pain is severe and they can't sleep, so this is one of the indication of total knee replacement. So okay. You see, this is X-ray manifestation of osteoarthritis. There is decreased joint space, subchondral sclerosis, and subchondral cyst. You see that? This is very, very important to show you. This is the medial compartment. This is the lateral compartment. You have to compromise the medial compartment from the lateral compartment. This is what we mean by the total knee replacement. You have to replace the tibial part and the femoral part by prosthesis to get rid from the pain. One of the important indication of total knee is the pain. Severe night pain. Osgood-Schlatter syndrome, one of the diseases in the knee joint, it is a disorder of adolescence that the tibial tubercle became painful and swollen. It is a traction injury by patellar tendon and it may be bilateral. A young adolescent complains of pain after activity and of a lump which stands over tibial. X-ray may reveal fragmentation of the apophysis. Treatment: spontaneous recovery is usually, but takes time with restriction and of activity as cycling, jumping, saucer. So, one of the causes is cycling, jumping, and saucer. If you decrease these, the pain also decreases. This is Osgood-Schlatter disease. You see, this is the tibial apophysis. There is fragmentation of the apophysis, and the patient gets pain. He can't extend his knee against resistance, and severe pain sometimes happen. So you have to decrease the activity of this child. You see this also? You see this also?